next speaker is Dr. Suellen, who is a senior lecturer and consultant in pediatric anaesthesia and pain medicine at Great Ormond Street Hospital. And her research interests include evaluating age-related changes in pain response and the long-term effects of early pain and injury. So thank you very much.
Thanks very much, and thank you for the invitation to speak, and also for including paediatrics in the program. And Alan will also be speaking later in the day. I'll go through this reasonably quickly because we're running out of time. But just to show some data that children are also getting opioids, so about 20 to 30% of hospitalised children in the States are receiving opioids. It increases the older they are. The actual prescription of opioids for children has been stable for many years, and compared to adults is very low. These are families who have children who are getting opioids, and in contrast to the rapid increase in adults. Now, whether that's appropriate or not is another issue, and also you'll notice that 40% of the scripts relate to coding, and we'll come back to that. The other issue is that there's a lot of variation with age, with older children tending to get more opioid prescriptions, but it's the older children who are having more trauma as well, and so it's probably related to their condition. In terms of the actual dose requirements for opioids, there's huge variability. So in paediatric practice, we can be dealing with anything from a few 100 gram preterm neonate up to 150 kilogram adolescent. And so there's obviously a huge difference in both age, body weight, and type of condition. And all of those will influence opioid requirements. And these are data just from neonates up to older children, but there's also huge individual variability, and so clearly we need to assess and titrate against response, as Pam was saying. There are clear pharmacokinetic reasons for changes in dose requirements, so changes in clearance and half-life in the younger children, but also significant developmental changes in pharmacodynamics, which are harder to really investigate, and we really need lab studies to look at that. But it's clear that there's alterations in receptor expression, both the degree and distribution, in the dorsal ganglion, the spinal cord, and the brain throughout development, which mean that even though you have the same tissue concentration, you're getting a much greater effect at most areas, and that's both in terms of analgesic efficacy and also side effects. The other thing with having access to a lab, we can actually look at the effect of opioids more specifically in relation to a surgical injury at different ages, and we've shown in the lab that we do see dose-dependent analgesia with opioids at all developmental stages. It does reduce CFOS expression in the cord, so this is after incision in a neonatal animal. We see a reduction with opioids, but nowhere near as effective as we see with cyanotic local anaesthetic block. Importantly, from a developmental point of view as well, we're dealing with an immature nervous system. Despite that, we don't see any local toxicity in the spinal cord with opioids. If we push the dose to 300 times the analgesic dose. And developmental cell death or apoptosis with general anaesthetics is a huge concern in paediatric anaesthesia at the moment. Opioids seem not to cause as much as general anaesthetic agents, but there haven't been good head-to-head comparisons. The other thing that we need to think about is that there is evidence that surgery in early life has a long-term effect that we don't see at older ages, both in terms of more acutely sensitizing the cortical response, greater than we see at older ages, but also long-term alterations in the response to future incision. And we've got a couple of posters at the meeting if anyone wants to follow that up. So clearly, for neonates and infants having surgery, we need very good analgesia, both acutely and for the long-term impact. What type remains to be determined. Type of surgery, as well as I mentioned, also have a big impact on opioid requirements, as you'd expect. Some of the specific sort of situations that have been looked at in children, increased opioid requirements in children with sickle cell disease, with cancer having major surgery, and also having surgery in the same dermatome as prior neonatal surgery. So again, this sort of persistent effect that we've shown also in the lab. The patients that I see on the pain round, that really I find opioids are inadequate alone, or we get dose-limiting side effects, particular surgery, particularly scoliosis and pectus surgery in adolescents, children with neuropathic pain either related to surgery or related to intercurrent treatment, particularly chemotherapy and vincristine, and also other cancer treatments. So mucositis is a big problem for our service. Adverse effects, respiratory depression, the rate in children has been reported at between 0.1 and 0.4%. And again, as Pam said, it really depends a lot on the definitions that are used. These are just a couple of large audits that have been conducted in the UK. This was a prospective audit for 12 months of 8 centres in the UK. Looking at either patient-controlled, nurse-controlled or continuous opioids, 15 cases of respiratory depression, one of which progressed to cardiac arrest. In nurse-controlled analgesia, and this is from Great Ormond Street, where I work, where we have a prospective database of all the acute pain patients, 10,000 post-op patients, and 39 cases of respiratory depression, and this was defined as children who had significant sedation and required naloxone. If we look more closely at that group, younger age and neonates are clearly overrepresented, but there are cases right across the age range. And in children, or in the neonates at least, we saw both a decrease in respiratory rate and an increase in sedation score. But when you're dealing with a respiratory rate of around 30, it's perhaps easier to see a difference. We don't have any, this is just data collected after the event, so we don't have anything to say which measure was more sensitive. The preterm children and those with pre-existing apnea, obviously a high-risk group. And what we found that was not the total dose that was important. So for the neonates who are getting respiratory depression, they weren't getting higher doses than the others. But one issue early on, we were using background infusions, and that was clearly associated with an increase, and so we don't do that anymore. Comorbid conditions as well, again across both of the large audits. Children with neurodevelopmental delay or intercurrent respiratory and cardiac problems were overrepresented. Minimising adverse effects, and again, one of the problems that is perhaps more marked in paediatrics is also the risk of dose errors when we're dealing with such a wide age range. And certainly both the audits picked up both programming and prescribing audits, most of which were identified by routine cross-checks, but there clearly has to be a very robust system for doing that. In a survey from Toronto, they looked specifically at 10 times dose errors again, which is something that's relatively easy to do if you're dealing with a wide age range. And this was occurring most frequently with opioids. So 18% of their dose problems were specifically with opioids. What we do and what many paediatric centres do is base what we put in the syringe on the weight of the child. So for us, we put 1 milligram per kilo in 50 mils. So for every child, there's 20 mics per kilo per mil. Now in this study, they looked at syringes that were made up either by pharmacy or by intensive care and showed some inaccuracies and suggested that everyone should have standard concentrations. And I really think this would actually be a much bigger problem because, trying to adjust how much volume you need for a small neonate, working out how much they weigh, doing the concentration, working that back, I think that would actually cause a huge problem. and really sort of 10% inaccuracy if you're titrating against effect is not the main issue. In terms of reducing dose requirements, we've heard about multimodal therapy, and there is evidence in pediatrics as well that non-steroidals will reduce opioid requirements both in the recovery room and for the first 24 hours. We did a systematic review looking at non-steroidals and paracetamol or acetaminophen, and found overall about a 30 to 40% reduction. But again, as Pam said, all the studies were too small to show any difference in respiratory depression, and only some showed a difference in post-operative nausea and vomiting. Paracetamol, lots of problems with the rectal preparation. It rarely gets to adequate plasma concentrations, more effective if it's given IV. But the other sort of difficulty with combining the data is there's such big variability in the study design. So if you're having repeated doses of non-steroidal or paracetamol and either PCA or NCA opioid, there's a much more consistent difference. If you're just looking at whether a bolus of opioid is given in recovery, huge variability, and mainly because there's a lot of variability in the analgesia that was given intraoperatively. Codeine is a big issue currently in pediatrics. As we all know, it's a prodrug, it needs to be metabolized, but there's huge variability in the ability to do that. Now, in the past, we were most concerned about the poor metabolizers and reduced efficacy, and that was certainly shown in this study some years ago, where children given codeine needed rescue analgesia much earlier. You wouldn't be able to do that study these days now because of concerns about codeine and associations with life-threatening or fatal respiratory depression, resulting in a lot of regulatory bodies now excluding the use of or recommending against the use of codeine in children under 12 and also in older children who are having tonsillectomy or who have disordered breathing. And I'm not really sure how you would define disordered breathing. Iatrogenic opioid withdrawal as well is something that we see a lot in children, and again, very like in adults, cumulative dose is important, duration in PICU. In terms of age, there seems to be a sort of double hit, if you like, in that neonates and infants have a very high dose. And I suspect that that's because they're the ones that are in ECMO and they're also in NICU for a long time. But then over 6 years, the doses are getting higher and there seems to be a higher peak again at older ages. And not surprisingly, the usual sort of process factors, if you like, associated with that. Lack of standardised sedation protocols or weaning protocols so that there's not titration down before the kids leave ICU. Continuous infusions, use of fentanyl, and also failure to recognise and assess. And there are specific withdrawal assessment tools for use in children. In terms of the other sort of major concern with opioids at the moment is using neonatal intensive care and the impact on neurodevelopmental outcomes. And preterm children most at risk. And I won't go into this in great detail, but there has been a lot of work looking at the use of routine morphine for ventilated neonates and controversy about those effects. Certainly, giving a large dose and having associated hypotension is a problem, but some more recent studies with follow-up at lower doses haven't shown consistent differences. Procedural pain and or morphine. Again, a large number of studies showing associations with alterations in CNS structure and cognitive and motor function, but clearly it's very difficult to tease out the individual contributions of pain or morphine. And surgery also has an added impact on cognitive outcome, particularly in very preterm children, and I'll be talking about this on Friday. But in the extreme preterm cohort that I've been working with, at 19 years they have about a 10 drop in IQ compared to preterms that haven't had surgery. So it is a big effect, and it's persisting for a long time. Has there been changes in practice associated with this? And I think really this is the only thing you need to notice, that the balance between adequately treating pain and not over-sedating using with narcotics in neonatal intensive care is still a big concern. So are perioperative opioids obsolete? I don't think they are. Perhaps as sole therapy they are. Clearly, we need to minimise the dose by assessment and titration against response and multimodal therapy. And then there are specific developmental considerations for if we're working in paediatrics, age-related changes in the kinetics and dynamics, specific issues related to preterm neonates and use in NICU, and also in terms of neonatal surgery where we need to clearly provide safe and effective analgesia, looking not only at acute outcomes but also long-term outcomes in terms of both pain and neurodevelopment. And I'd finally just like to put in a plug for the ISPP in Kuala Lumpur next year. Thank you.
So thanks for your talk. I really appreciate that we, during the first part of this meeting, not just hear about the bad news, but you mentioned some good news about opioids, and I think this is a big message as well. We need the opioids, at least at this time, when we have no holy grail that's better than opioids, and I really like this message as well. Other comments? Questions? Please. How much time? Oh, we have some 3 minutes for one question.
No, I don't want to be the only one asking a question, but I think this session was expressed very, very interesting to me, and one of the points that was made was concerning the fact that we, to prevent adverse events with opioid, we should not look only at respiratory rate. And I think in the discussion of a multimodal approach that we have, and I come back to the gabanoid, the drug, the sedation that we provoke in this patient post-op, especially during the first 24 hours, is very, very significant and need to be taken in consideration. And I would like to bring that as a point of discussion. The other point of discussion, if I may, concern the good prescribing practice of opioid, because we have, when I look at the article of Lee, and I see 46% of patients who have dual administration of opioid, intrathecal and peripheral, I say we have a problem here. When I see patients who have a PCA and have a continual basal rate, when they just have a normal and a surgery, they don't have any history of chronic pain, I see a very big problem here. Then my question to the speaker is, what is the value or the role of this bad prescribing practice in all of what we see every day?
I think that's a big point, and we are able to discuss this later on during the meeting, during the coffee breaks. We are able to talk to the speakers as well. I hope everybody will stay the whole meeting. And Jane, do you want to say something?
That's so exciting, actually. So I think that's a really good point and worth discussion. And although we're the experts who can take all this information home, the problem is getting to the junior doctors who are doing prescribing, or some of our anesthetic colleagues who are doing the perioperative prescribing, to make sure they understand it. Because I think still, after all these years of using opioids, so a lot of these messages just haven't got through. So, without further ado, to take back to the country, let's go for coffee now, and if we come back at 11 o'clock to start our next session. So thank you very much, and thank you to